Hi, my name is Justin Oldham. I'm an assistant professor of medicine and director of the Interstitial Lung Disease Program at University of California at Davis. Today I'm going to be giving a talk titled Interstitial Lung Disease Educational Series, a Disease Overview. This presentation is presented as a joint educational initiative by the California Thoracic Society and Boehringer Ingelheim. So first, my disclosures. I have a few grants to study idiopathic pulmonary fibrosis from the NHLBI as well as Department of Defense. I have a grant to study early ILD detection that's funded by Boehringer Ingelheim, and I do ILD consulting for Genentech, Boehringer, Amex Bio, and Gatehouse Bio. So objectives of this talk are to provide a framework for interstitial lung disease classification, review the ILD diagnostic workup, and highlight the importance of early detection. So first, with ILD classification, we have a traditional approach, and then we have a newer paradigm, which we have a shared pathobiology approach. We'll talk about each. So here's the traditional approach. Pulmonologists looking at this will recognize this as we learn it every decade or so, and we're reboarding. We generally split interstitial lung disease into etiology known and etiology unknown. And so first, to the etiology knowns, we have inorganic exposure-related ILDs. These are primarily occupational, asbestosis, silicosis, that sort of thing. We have more environmental exposures like birds, mold, mycobacterium. We have smoking-related ILDs, desquamative interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, and Langerhans cell histiocytosis. We have drug-related ILD, which we're not going to talk about a whole lot. This doesn't tend to cause fibrotic ILD, more of an acute inflammation. And then we have connective tissue disease, ILD, which is quite common, namely rheumatoid arthritis, the idiopathic inflammatory myopathies, which used to go by dermatomyositis and polymyositis, and then scleroderma or systemic sclerosis. On the etiology unknown side, these are primarily made up of idiopathic interstitial pneumonias, of which idiopathic pulmonary fibrosis is by far the most common. We also have a few types of non-IPF ILD that we see, which are these here. We're not going to talk a whole lot about these. So when we think about ILD pathogenesis, there are two general mechanisms of injury. We have injury of whatever etiology that leads to inflammation, and then fibrosis. This is seen most commonly in diseases like hypersensitivity pneumonitis, as well as connective tissue disease, ILD. And then we have diseases where there's injury resulting directly in fibrosis, and this is what we see predominantly in patients with idiopathic pulmonary fibrosis. There is a genetic predisposition that likely increases the risk of developing ILD. We know that there are HLA loci that are associated with disease in CTD as well as hypersensitivity pneumonitis or CHP. We know that the MUC5B promoter polymorphism as well as rare and common variants in TERT and TERK have been linked with differential risk for idiopathic pulmonary fibrosis. So now the shared pathobiology approach, which is viewing ILD through a spectrum of overlapping inflammation and fibrosis, with some disease being predominantly fibrotic, some being predominantly inflammatory. On the inflammatory side, we see early interstitial lung disease due to connective tissue disease. We see early hypersensitivity pneumonitis, cryptogenic organizing pneumonia, cellular idiopathic NSIP, and drug-induced ILD. On the fibrotic side, we see later manifestations of connective tissue disease, later manifestations of hypersensitivity pneumonitis, as well as idiopathic pulmonary fibrosis, fibrotic idiopathic NSIP, and asbestosis. What's important to know is that whether it is an inflammatory predominant ILD or more of a fibrotic predominant ILD, each of these can result in a progressive fibrosing phenotype, with idiopathic pulmonary fibrosis being the most likely to do so, as nearly all patients with IPF will develop a progressive fibrosing phenotype. So let's talk about the inflammatory ILDs a little bit first. These can manifest in different ways on high-resolution CT as well as lung biopsy. Here are a couple images that we see quite commonly in patients with inflammatory ILD. This on the left is a nonspecific interstitial pneumonia pattern, and here on the right is an organizing pneumonia pattern. Nonspecific interstitial pneumonia, or NSIP, has more of a basilar-dependent ground glass pattern with areas of subpleural sparing. The organizing pneumonia on the right here can look a lot like infectious pneumonia, where you have air bronchograms, some degree of centrality, but rather than being an infectious pneumonia, it's more of inflammatory cellular pneumonia. Now let's look at fibrotic interstitial lung diseases. This pattern here on the left, you see peripheral predominant fibrosis. This pattern is called usual interstitial pneumonia. Here on the right, we see more of a central and upper lobe predominant disease process, which is consistent with hypersensitivity pneumonitis. There are corollaries to the CT patterns that we just saw on histopathology, and here they are. So with the inflammatory ILDs, the corollary to nonspecific interstitial pneumonia on CT is NSIP on histology, and that can be a cellular pattern like we're seeing here, where you get fairly uniform widening of the interstitium with infiltrate of lymphocytes and other inflammatory cells, or you can get the organizing pneumonia pattern that we're seeing here on the right, which again is filling of the airway with cellular material. And as we have fibrotic predominant CT patterns, we also have fibrotic predominant histopathology patterns. Here on the left is usual interstitial pneumonia with temporal heterogeneity. Right in the middle there, we see a fibroblastic foci, which is characteristic of UIP. And then on the right here, we see more of an airway-centric fibrosis, which is very characteristic of hypersensitivity pneumonitis. So the next few slides, I'm going to talk about the interstitial lung disease evaluation. This includes a standardized workup, avoiding unnecessary interventions, and a multidisciplinary discussion. So for the interstitial lung disease evaluation, we want to be very systematic in how we go about it. History is incredibly important in working up ILD. We want to ask whether the patient has pertinent environmental exposures like birds or mold that can indicate a diagnosis of hypersensitivity pneumonitis. We want to know whether they have stigmata of connective tissue disease, including joint pain, swelling, rash, muscle weakness, and others. We want to ask them about new medications, as these can cause a drug-related ILD. We want to know about job exposures. These tend to be remote, but getting a thorough history of what the patient does and did do in their history is important. Want to know if the patient has a family history of ILD. This could indicate a familial form of the disease that can act very much like IPF. Want to know if they have a smoking history. This could indicate a smoking-related ILD. Also want to inquire as to whether other systemic processes are occurring. Does the patient have early graying? Are there bone marrow abnormalities like MDS or a history of hematologic malignancy? Does the patient have liver disease of unclear etiology? All of these could indicate a short telomere-related ILD. Next, we want to go to physical exam, looking specifically for autoimmune features. Want to do a thorough lung exam, listening for crackles and other features that we can hear, like in hypersensitivity pneumonitis, you can hear squeaks and pops. Want to do a thorough laboratory workup. This includes autoimmune serologies. And then we go to high-resolution CT scan. This can be as important as history in that we can see a fibrotic predominant process here, like this usual interstitial pneumonia pattern. You can see more of an inflammatory predominant process here with the NSIP pattern, or we can see more of a disease-specific type process here, which is a patient that has hypersensitivity pneumonitis, which is characterized by upper lobe disease and mosaic attenuation. Pulmonary function tests are also a very important piece of the ILD evaluation. This allows you to characterize physiologic deficits, primarily forced vital capacity and diffusion capacity, both of which are well-known predictors of subsequent outcome in ILD. This facilitates prognostication. These survival curves on the right here were produced by Brett Lay and the UCSF group, showing what various thresholds of FVC and DLCO, how they're associated with survival. And then the serial PFTs allows for monitoring of disease progression. While baseline forced vital capacity and diffusion capacity are well-known predictors of subsequent survival, we also know that serial change in each of these metrics are good prognosticators for patient survival. So there are a good number of patients for whom history is unrevealing. The physical exam is nonspecific, laboratory workup is negative, and the high-resolution CT is non-diagnostic. At that point, we will often label these patients as unclassifiable ILD, and we will refer them for a surgical lung biopsy. It's important to note that the patient must have sufficient lung function in order to undergo this procedure, but that it is largely safe, while acknowledging that there are small and finite risks of death or exacerbation. And so you have to choose the patients carefully who you're going to send for surgical lung biopsy. But with surgical lung biopsy, you can get very helpful information like this usual interstitial pneumonia pattern here on the left, or more of a cellular NSIP pattern here on the right. So when considering sending a patient for a surgical lung biopsy, it's important to discuss with them that there are risks associated. This paper published a couple years ago assessed 30-day mortality after surgical lung biopsy, and found that depending on the year in question, there was a 5 to 10% risk of 30-day mortality afterwards. This was driven by several different factors that are important to note, however. One is volume. Hospitals that do more of these tend to have better outcomes. Another was the type of procedure done, with open thoracotomies having worse outcome. But this was driven in by a large extent to those being done in non-elective cases. And so if you look in between these two boxes here, you can see that a non-elective surgical lung biopsy had an 8-fold to 9-fold even increased risk of death. And so while there is an increased risk of poor outcome in those undergoing surgical lung biopsy, it's important to note that this is driven primarily by patients who are undergoing this procedure on a non-elective basis. Most data show that those undergoing surgical lung biopsy on an elective basis tend to have mortality in the 0.5 to 2% range, which we do view as acceptable when needing an accurate diagnosis. Next, we're going to talk about bronchoscopy. There's some increasing questions around the use of bronchoscopy in patients with interstitial lung disease, and I'm going to address a few of these. Up until recently, this was generally of limited use, with a few notable exceptions. Hypersensitivity pneumonitis could be diagnosed in the correct clinical context and is supported with a high lymphocyte count, and so cellular analysis can be quite helpful in these patients. Sarcoidosis, of course, is one for whom bronchoscopy is performed regularly. This can include lymph node biopsy as well as transbronchial biopsy. Asbestosis can be helped with bronchoscopy in that you can do a cellular analysis as well as histology and see the classic asbestosis fibers. Drug toxicity can be helpful. You can see particular patterns, including amiodarone toxicity and others. And then now, more recently, we have this genomic testing for histologic UIP, which can actually increase your diagnostic confidence in IPF. Nowadays, cryobiopsy is becoming increasingly performed. This can help establish a diagnosis in patients who cannot safely undergo a surgical lung biopsy. It is important to note that there's higher risk of bleeding and pneumothorax in these patients, but they do have pretty similar diagnostic confidence as you get with surgical lung biopsies. And it's also important to note this is highly operator dependent. Speaking to the genomic testing of UIP, this is a study that was published in 2019 by the group who developed this test. And what they found was that when you have this gene expression-based classifier, you're able to identify UIP with roughly a sensitivity of 70 to 80%, as well as a specificity of approaching 90%, which gives you a positive predictive value of roughly 80%. And so you can say with pretty high degree of confidence that when this test is positive in the correct clinical setting, that you're making a diagnosis of idiopathic pulmonary fibrosis. And so when we talk about cryobiopsy, you get a nice sized piece of tissue here, which is substantially larger than what you get with a normal transbronchial biopsy, which is only about 1 millimeter in diameter, but smaller than you get with a surgical lung biopsy, which is shown in the far right panel here. This is the cold ice study, which was published by the Australians recently, which they showed that tissue obtained by transbronchial lung cryobiopsy was resulted in a similar percentage of diagnoses as when obtained with surgical lung biopsy. These were in paired patients where both were performed. And as you can see, the percentage of biopsies were roughly similar between the two. There are, of course, complications to be aware of. As I mentioned, you get airway bleeding. These guys did a great job in that they didn't have much in the way of serious bleeding. Actually, they had none, and they only had one pneumothorax. But these are complications that you need to be aware of when sending a patient for a cryobiopsy. They also did see that there were acute exacerbations and one death after this, which was on par with what we see historically in patients with undergoing surgical lung biopsy. Next, I'm going to talk about the multidisciplinary discussion. And so this is some language from the American Thoracic Society, published back in 2013, just outlining the individuals that should be involved in the MDD. Also listed below here. So you have an ILD pulmonologist, ideally with some degree of ILD training, a chest radiologist, pulmonary pathologist, ideally have rheumatology involved, of course, your nursing support and your research coordinators. Together, this group not only achieves a higher confidence diagnosis, but it can also lay out a treatment plan and follow up when more information comes in. So the Michigan group did a very nice study looking at what the outcome of MDD is. And what they did was they had a stepwise approach where they had individuals provide their diagnosis, and then you gave the individuals some standardized clinical information. You had a group discussion where you had just the radiology findings. Then you had a group discussion where you brought in the pathology, and then another group discussion where you come up with a consensus diagnosis. And what you can see here is initially the clinicians had okay agreement. The kappa score of 0.4 here suggests moderate agreement between clinicians in the final diagnosis. But as you can see, with each increasing step, that confidence goes up, such that by the time you get to step 5, where everybody is talking and coming up with a consensus diagnosis, that agreement goes up to 0.86, which is considered excellent agreement. Same sort of thing goes for the radiologists and the combination. As you increase in these steps, more standardized and more information coming in, you get a much higher confidence diagnosis and much more agreement. And so this is one last piece as to why it's important to get patients to a center of excellence. This was a study published by the Columbia Group back in 2011, looking at the time it took for a patient to be referred and evaluated at a center of excellence. And as you can see here, even after adjusting for duration of disease, you can see that those who waited longer to receive evaluation at the center of excellence had worse outcomes compared to those that were referred promptly. So I gave you a lot of information on how we classify patients. Next, the question is, does this classification matter? And I will argue wholeheartedly, yes, it definitely does. And so, first of all, survival varies substantially by ILD subtype. And so, if you have IPF here, you have connective tissue disease here, you're doing a patient a disservice if you provide them a prognosis on par with IPF when they actually have a connective tissue disease, or vice versa. This is a group that isn't quite IPF, isn't quite CTD, we call IPAF. And as you can see here, their survival falls somewhere in between, and we're still trying to better characterize this group. So getting to my previous point, you don't want to tell a patient they have 10 years to live if they actually have roughly 3, and vice versa. And so while survival can vary by ILD subtype, it also can vary in those with similar morphology. So this is some internal data across 4 centers that we've collected, and we compared patients with IPF who always have a usual interstitial pneumonia pattern, either by CT or by biopsy, and we looked at their counterparts with CTD ILD who also have UIP. As you can see here, there's clear separation between the CTD group and the IPF group. And so it's important to note that UIP does not always mean IPF. Even if you see UIP, you still need to do that standardized workup we discussed. And so why else is classification important? Well, as you can see here from this Kaplan-Meier curve in patients with hypersensitivity pneumonitis, once you diagnose that disease, much of the work we do is focused on finding an inhaled antigen. And as you can see here, those who have an identifiable inhaled antigen and that we presumably remediate or remove from the environment do much better than those for whom we can't identify an antigen. And so classification is very important for those patients because you can really impact their lives by getting rid of what's causing their ILD. Classification is also important because if there's some degree of suspected autoimmunity, referral to your rheumatology colleagues is very important because, as you can see by this study just published last year, patients with IPF and HP who were initially received this diagnosis through an MDD were referred to rheumatologists and ended up with a lot of different diagnoses here. And so ILD classification is important not only for prognosis but getting the right diagnosis, and you want to bring in as many of your colleagues as you can in this process. So early detection remains an unmet need in this group. This is a paper published by the Pulmonary Fibrosis Foundation where you can see how long patients waited for a diagnosis, and 29% of patients waited more than 2 years. About 20% of patients waited 3 years from the time of symptom onset to receiving their final diagnosis. As you can see here, misdiagnosis is also quite common. 55% of patients reported more than 1 misdiagnosis, and 38% reported more than 2 misdiagnoses. Okay, next we're going to talk about strategies to improve early ILD detection. The points we're going to talk about is educating that ILD features should not be ignored, better reporting of ILD abnormalities when present, screening of high-risk populations, and biomarkers to predict ILD presence. So first, features that should not be ignored. Obviously, crackles are one of the most common physical exam findings in patients with pulmonary fibrosis. And you can see in this paper that we published in Chest last year, if you have crackles, the specificity for ILD is 0.89, which is strongly suggestive of the presence of pulmonary fibrosis or ILD if crackles are present. They're very poorly sensitive for the disease, but when heard are very helpful. Also, if you see restrictive physiology, again, quite specific for ILD, terribly sensitive. If you see a DLCO less than 8% predicted, great test performance as far as sensitivity goes. You will capture most patients with ILD if you look at patients with a DLCO less than 8%, but pretty poorly specific because a lot of different diseases can cause a low DLCO. Next, let's talk about interstitial lung abnormalities. These can be detected on CT performed for many different non-ILD indications. And so this is a nice paper by the Brigham group, just showing what various types of interstitial lung abnormalities can look like. These can range from very subtle subpleural abnormalities to more overt-looking pulmonary fibrosis in somebody who's otherwise asymptomatic. And so in this paper, we see that progression occurred in a much higher percentage of patients who did have ILA, such that about 75% of patients who have ILAs will progress over time. So these should be taken seriously. Not everyone will develop clinically overt disease, but it is important to note that a lot of these patients will progress over time. Here's some additional data showing why interstitial lung abnormalities are important. This again from the Brigham group in Boston. They looked at the Framingham Heart Study as well as the Aegis Reykjavik study and found that patients with interstitial lung abnormalities had almost threefold higher risk of death compared to those who didn't in the Framingham study, and then about a 30% increased risk of death in the Aegis study. So these should not be ignored, and you will see reads of mild pulmonary fibrosis, but don't mistake mild for early. We try not to use the term mild anymore because these really should be viewed as early disease, and that notes that you can do something about it. So next, let's talk about better reporting of ILD and ILAs when present. This was a paper we published in Respiratory Research in 2019, where we looked at the mention of interstitial abnormalities on chest CT and abdominal CT. What we found was that when the CT findings of interstitial abnormalities were mentioned by the radiologist, it did result in a much more prompt referral for pulmonary evaluation. So it's important to drive home to our radiology colleagues that even if a CT is not being done to assess for ILD, reporting these features is very important. And that's not just reporting them in the body of the text where they may be missed, but also carrying them forward to the conclusion so that anybody who's reviewing the report can acknowledge that there are interstitial abnormalities present and hopefully do something about it. This is a paper that we published in Annals ATS in 2018, just looking at ILA reporting in patients undergoing lung cancer screening CTs. We did, as others, notice that roughly about 10% of patients undergoing lung cancer screening CT had some degree of interstitial lung abnormalities, and that when those were reported, you see a much higher percentage of patients who were referred for ILD evaluation than when they were not reported. It's important to note that still half of patients for whom they were reported did not receive a referral, so reporting is not the entire story here. We also need to make it known to the primary care docs who are ordering the lung cancer screening CTs that referral in any patient that has interstitial abnormalities is important. Next, we're going to talk about screening of high-risk populations. So first off is familial pulmonary fibrosis. This is a group that has obviously very high risk of affected family members developing clinically overt disease. This is a nice paper by the Brigham group looking at a single family who had familial disease. And as you can see here, the chest CT images can actually vary quite a bit. Patients can have ranging anywhere from no disease to overt ILD to just interstitial lung abnormalities. They can have no pulmonary function abnormalities. They can have a lot of pulmonary function abnormalities. And then when you look at their telomere lengths, they can be all over the map here. And so it's important to note that disease that runs in the family can manifest in a lot of different ways, and simply having a family member, a first-degree relative affected with pulmonary fibrosis, makes you a high-risk individual that should be screened in some degree for familial disease. And so the next group we'll discuss is autoimmune disease, namely systemic sclerosis, rheumatoid arthritis, and myositis. There are, of course, other autoimmune diseases that can result in interstitial lung disease, but they are less common. This is a consensus statement that was published in the Lancet Rheumatology last year, proposing screening of interstitial lung disease among patients with SSC. And as you can see here, they are recommending that all patients with SSC receive a high-resolution CT scan to look for ILD, and that's because it's so common in this patient population. A little bit less so in rheumatoid arthritis, but it's also quite common in myositis. And so I'm of the opinion, and I think a lot of others are in the field too, that these three groups all should have a high-res CT to look for ILD. And if you see it, then you need to do your standard ILD workup and make sure that you're interfacing with the rheumatologist to make sure that systemic autoimmune disease is being treated effectively along with the interstitial lung disease. If you're not seeing high evidence of interstitial lung disease on the high-res CT initially, then you do want to monitor these patients serially, often with pulmonary function tests and a CT at some interval. It's important to know that CT is not without risk, and so if you have a younger patient, you want to weigh the risks and benefits of doing serial CT in those patients. Next is those undergoing pulmonary function tests. This is a paper that my group published last year, which we derived a prediction tool for interstitial lung disease based on pulmonary function test metrics. And what we found was that primarily in patients with cough or shortness of breath, if you applied this tool, which performed better than your run-of-the-mill PFTs for looking for ILD, it did result in a higher percentage of patients undergoing confirmatory CT. And so we're looking to further develop this and hopefully can start applying to anybody with cough or shortness of breath who's sent for a PFT. Another group are those undergoing lung cancer screening CT, as I mentioned earlier. These patients do have a high prevalence of ILD. This group here was 10%, which is pretty similar to what we were seeing. And so anytime 10% of a population has something, it's worth looking closely at them for your disease of interest, in this case, interstitial lung abnormalities. Another group are those undergoing cardiac surgery. This tends to be an older population. We looked at 600 plus patients who were referred to our hospital for cardiac surgery, namely TAVR, and we found that about 14% of those patients actually had ILAs or evidence of ILD. And as you can see in the Kaplan-Meier curve here on the right, those patients tended to do worse. And so identifying them up front, interfacing with your cardiology colleagues to ensure that these patients are properly risk stratified is important. Finally, I'm going to talk just briefly about biomarkers to predict ILAs and ILD. The Brigham group has done really nice work in this arena and just recently published a paper finding that a handful of different biomarkers, which are known biomarkers of biologic aging, are predictive of interstitial lung abnormality presence in these patients, namely GDF15, tumor necrosis factor receptor, IL-6, CRP, and insulin. And so this is really exciting work because it could indicate that we may, in the future, have a way of non-invasively screening for ILD without a CT, without a PFT, just getting a blood test and going from there. So this is very exciting. All right, in summary, ILD subtypes are numerous, but often have an inflammatory or fibrotic predominant endotype. A standardized ILD workup, including MDD, is important and represents really a cornerstone of ILD centers of excellence. An accurate diagnosis is critical both for prognostication and appropriate intervention. And finally, early recognition is critical and an ongoing unmet need. Thank you for your time and attention, and thanks to the California Thoracic Society and Boehringer Ingelheim for sponsoring this activity. Now we'll take any questions and answers. Thank you.